Welcome back, everyone. It's my great pleasure to introduce our plenary speaker for this afternoon. Nelson Sewankambo is a Professor Emeritus at Makerere University. He's the former Dean of the Medical School and also the Principal of the College of Health Sciences. I personally can attest to the huge numbers of years of capacity building, international collaborations, huge amounts of work around the world to connect fantastic Ugandan and wider African scholars with counterparts, including a Sewankambo Scholars Program, of which I think there were 13 PhD students, and almost all of them, if not all of them, I know, are still working at Makerere and have gone on to be, one of them was just appointed a full professor this week. So a huge amount of work in capacity building, collaboration building. He's the PI of the Thrive and Deltas programs, which are initiatives with Cambridge and the London School, which he's going to talk to us about this afternoon, but is also a fellow of the African Academy of Health Sciences and the Uganda National Association of Scientists. So Nelson, it's lovely to have you back in Cambridge. We give you the floor. Thank you so much.
Thank you very much for that kind introduction. Yeah, silence is to keep you in suspense. Okay, so that's the title of my presentation. And I chose this title because of what I saw advertised as the focus of this day today. And that is around innovation, collaboration, and education. And I thought that this fitted the bill. So as you can see, there are a number of institutions that we've been partnering with on this collaboration. So Thrive is a Delta's research consortium, and I'm saying here that it marks a decade of progress. Because those abbreviations will keep occurring, I thought I would explain, first of all, what those abbreviations are. Because I know in this crowd, there's perhaps two people who appreciate these abbreviations. That is myself, because I've been in it since we started the partnership, and Kevin Marsh, because he's been there right from the beginning, and he's a designer, an engineer of what these programs have looked like. Thrive is training health researchers into vocational excellence. So our program is called Thrive because we wanted to support people to thrive, and so we ended up with Thrive. IESA, the Alliance for Accelerating Excellence in Science in Africa, that has been in existence in the last 6 years, perhaps, but it is no longer in existence according to my understanding. Then Deltas. What is Deltas? Developing Excellence in Leadership, Training, and Science in Africa. That started 6 years ago, and it is still ongoing. In fact, they just awarded late last year the second cohort of collaborations for support under Deltas. And then there's SFA Foundation. That is the Science for Africa Foundation. And you'll hear more about it in the years to come, because this has taken over the responsibilities or the work that IESA was doing. And we will not go into the reasons why. So the content of my presentation will give you a flavor of what is the Thrive focus, what are some of the Thrive achievements, and then looking into the future, because this is what this day is focused about. And specifically looking into the future, I thought the grandest challenge in global health needs to be discussed also now. So Thrive has a vision, and this vision was coined nearly 2 years ago. Africa is that is before actually COVID pandemic started. Africa is at a critical crossroads where, despite rapid development and scientific progress, the persistence of highly endemic infectious diseases, many of which are neglected diseases of poverty, are now increasingly interacting with rapid rise in non-communicable diseases and with newly emerging and re-emerging, often zoonotic infections. And of course, COVID is one of those zoonotic infections which has emerged. This, of course, it is a long vision. You would have liked perhaps to see a shorter vision, but this captures our what we were thinking at the time 2 years ago. And this vision also speaks to the grandest challenge in global health. And you may be asking yourself, what is the grandest challenge in global health? I believe the work that is being done by all those involved here in Cambridge, Africa today, they are doing global health, work related to global health. And we will get there shortly. And she told us she's a coordinator or director of global health here. So the Thrive Network, because it started, when it started, we got funding from the Wellcome Trust, and then we joined the Deltas 6 years ago. We came up with the theory of change that captures also what Deltas were about. And here, we represent it as having 4 pillars on which our theory of change is. And the fact that we wanted to strengthen research institutions and individuals as researchers, we wanted the institutions within which we work to have an environment that really supports research. And therefore, we looked at strengthening research administration as one of the important things, in addition to individual researchers, because many times we neglect thinking about research administration and management, and we focus on the individual researchers. So I also want to give you a flavor of, what have we done in the last so many years. But first of all, to let you know that when we started our program, the demand for PhDs training in PhD was not as high as what it has become. Even worse, the demand for postdocs. You talk to people about doing a postdoc, what for? Well, PhD is done and finished. But look at the number of applicants. In the first intake that we did, which is close to, it's about 9 years ago or so, 201 people applied for the PhD and 60 for postdocs. And yet the available slots that we had for each of those, it was 8 PhDs and 5 postdocs. Then in the second intake, which was 5 years ago or close to 6 now, the applicants were 132 for PhDs and postdocs 40. And the available slots awarded were that number. You can see that on the continent, certainly if this picture has to reflect anything happening around the continent, is that the demand for postdoc work and the demand for PhDs has gone up. And therefore, we need to think carefully, how do we meet this demand, we collectively who are participating here at this meeting and those who are elsewhere. So that is just a picture to show, the interviews that were taking place. We had a 3-step process through which you go if you apply to be taken on for PhD, and the same for postdoc. And this is one of those interviews. Probably one of the persons shown there is in this room. That is Dr. David Dunn. Now, we This is again to give you some understanding of what we've been working on in the Thrive Consortium. The main thematic areas extend from infectious diseases and neglected tropical diseases as well, maternal, neonatal and reproductive health, as well as non-communicable diseases. Of course, these themes do overlap or intersect somewhere, and this is what is supposed to be shown here. We are very interested in the intersection between infectious diseases and non-communicable diseases. Now, coming to Cambridge, our students or our fellows have valued it extensively because when they come here, they have protected time and they are away from the other challenges they have on a day-to-day. There is a coordinator who is full-time to look after their interests, to understand them, understand their research, and help them around various issues. They have opportunity to network with a wider group of researchers and students from different countries, and being affiliated to a college helps in networking as well as, of course, through the dinners and events that take place in those colleges. The quality of mentorship, they are able to compare the quality of mentorship they have in our African setting compared to what they get here. When I showed the first slide, I said there are a number of institutions there who are partners. So we extend, in Uganda, there are 3 institutions, in Kenya there is 1, in Tanzania there are 2. And these photographs are just to show you what every day when we meet, these are the kind of people who get together. Now, there are many publications that have come through this, as shown here. There are people, these people we support fully for PhDs and postdocs. Of course, because we give them a stipend to protect their time, they end up also doing some other work which is related to research and also working with students. And as you can see in the last column here, Thrive Cohort 1, 855 students that they worked with, 298. And that's the kind of payoff that comes with supporting these people. The publications, as you see here, they have been increasing over time. In 2020, because that's when the pandemic struck, that did not reach where we wanted it to go. We are married, and I use the word married, and married because we are very convinced now that public engagement is extremely good in improving research and also making sure that the research outcomes or results are utilized. So what Professor Samba or Dr. Samba was saying this morning is real music to our ears. And these photographs just give you a snapshot of what kind of engagement they do. There are challenges and opportunities for women.
I don't think the slides are progressing.
Oh, yeah, that's the photos I was talking about. Yes, public, oh, sorry. So I was lagging behind 3 slides. So you see the numbers, extensive numbers, 855, 298, because these fellows interact with the students and engage them in their research that they are doing. So the publications, as you see, they have been rising over time, except in 2020, by the way, that was not a complete year, that is up to August, but because of COVID, of course, the production was not as we had expected. Again, this is public engagement that I've been talking about. There are challenges and opportunities for women that we take on. And the challenges, for example, here in this picture, you can see that young lady, she's breastfeeding, she's trying to study, she has got another young baby sitting down there, and I'm sure in a few minutes that young one will get up to try and interrupt the mom with something. And so these are the challenges. And moreover, working in a small environment, the houses are not that big for all of them, and those are issues. There are structural barriers like family and social culture, community attitudes about women in science, and weak institutional supports. I've talked about working from home. But of course, there are opportunities for them and for us. We can learn from the UK partners, that is Cambridge and London School, how they are addressing this issue of women in science. And also puts in place some innovative solutions for addressing gender inequality. Some positive institutional policies exist, like in my institution, but the problem is implementing those policies. It is one thing to have a policy-supportive policy, it's another to implement that policy. And then the women have opportunity to join resource networks that support career development of women scientists in low and middle income countries. Here you can see a proud group of Thrive graduates having completed their PhDs. This was at a graduation ceremony. And you can see a number of women there. So this on the next slide, again, intended to give you an example of those women, female here, who are emerging as research leaders. And each of them has a fascinating story. The very first one there is still completing her postdoc, and she has already gotten a grant from NIH in the US of $2.5 million to research on epilepsy, which is her field. And the list goes on, but time does not enable us to go through. By the way, that very person, having gotten into public engagement as part of her research, she vows she will never do research again without first talking to communities very well and without continuing to engage communities in her work. In fact, she believes that she probably got that NIH grant because public engagement was strong in there. So these are male who are also emerging as leaders. And again, each of these people have fascinating stories. 3 or 4 of them are actually now adjunct professors to universities in the North. After going through what they went through and the kind of work they did and the partnership that was going on, they have been appointed as adjunct professors for those places. And again, a number of them have got several grants just having finished a postdoc or having finished a PhD. Look at Humphrey Mazigo here. I pulled out that one because David Dunn here was his supervisor. That guy, we met him three weeks ago in Tanzania. He's at the Catholic University, and he has 3 big grants. 3 big grants, and he's a happy camper. He has set up a lab which is helping him to continue with his work. So right now we are asking ourselves, which way does Thrive go? How much? 5. Which way does Thrive go? We didn't get the Delta's grant last year, and yes, we are involved in thinking, where does Thrive go? And there are key determinants to how we decide on this. One, the Delta's grant has ended. It ended actually end of last month, like 1 week ago. Delta's shift from IESA, I told you that IESA does not exist any longer, and instead there is Science for Africa Foundation. The COVID pandemic, of course, had its impact on people, institutions, and therefore we must consider that very carefully and its implication as we think about going forward. Shifting funders' priorities, we all know that again, partly because of COVID, they're shifting priorities and the constrained funding opportunities. African governments, what are our governments willing to do? At Makerere in Uganda, actually, the government in the last 2 years, for the first time, and I've been with the university for 40 years, for the first time, they are giving a lot of money. Of course, compared to the need, it is not that much, but in actual, financial terms, it's quite big to the university to stimulate research. And then there are the geopolitical events. As we know, the fights between Russia and Ukraine doesn't augur well for us. Now, moving forward, I think we should celebrate and build on existing success. Yesterday, I got this email. This is part of an email from one of our PhD trainee who is about to complete her PhD work. She said, and I thought I should pull it out, "Dear Professor, I'm pleased to tell you that my main PhD RCT results manuscript, and that's the title of the manuscript, has been accepted in the Lancet Global Health article reference that about the open access publishing, I'm required to pay an APC of $5,000 to Lancet Global Health. I kindly request Thrive 2 to facilitate this payment. While we celebrate her success, now there is the $5,000 to be paid. What does she do to move forward?" Of course, IESA had set up an online publishing, I don't even remember the name, but Kevin will remind me later. But here's the problem. We as academics, we ask the students, which high impact factor journal did you publish? And so the students feel they can't, they shouldn't go into that kind of journal because they'll be asked, which is this journal? What is the impact factor? And so they find themselves in a difficult situation. Looking to the future, innovation, collaboration, I ask, let's push the unfinished business forward, that is Thrive, and we should keep our collaborations going and resilient to future shocks. The kind of shocks we've had with the pandemic and sustainability. That's why I say, Thrive. Are you going to stop here? And the answer is an absolute no. We are not going to stop there, even though we haven't gotten the Delta's grant. We were trying to think, how do we sustain this? We should be more innovative. Since the theme today is collaboration, innovation, education, how are we innovating as we do the collaboration? Innovation in collaboration, innovation in education, and innovation in innovation. That is an important thing we have to think about. We need to tap into existing expertise and nurture our partnerships as equitable. And I emphasize the word equitable. It is great that our partnerships are equitable, but we can make them even much better. Reverse learning. I was very delighted when the speakers who are going on about Uganda Cancer Institute collaboration, they said they are probably learning something from Uganda Cancer Institute. Always the assumptions. People think we in the low and middle income countries are learning from the North. But there's something you are learning from the South. What are you learning? So I was very delighted to hear that kind of thing. And some of us are actually working on reverse learning and reverse innovations. And we need very good examples of where reverse learning and reverse innovation is taking place. Global health, the grandest challenge in global health. What is it? let me take, I hope I still have 3 minutes, to introduce you to what is the grandest global health challenge. These are two guys some of you would know. The very first one on the left actually started at Makerere, and in his fourth year at the end, he had to leave the country because the infamous dictator Idi Amin expelled Asians. And so he had to leave. But he came to London and was able to complete his education in 1.5 years there. And after that, he went to Oxford and did his residence, and then did a PhD there, and was on staff on faculty for 2 years before he moved on. This Peter Singer was, both of them, by the way, they were very instrumental in starting the Bill and Gates Grand Challenge. They were called in to think and think deeply how the Grand Challenge should look like. Now, what did these people do? They wrote a book. It was published in 2011. And this is cover page. Dr. Abdallah Dar, Dr. Peter Singer. The grandest challenge, as they saw it, is at the bottom. Taking life-saving science from the lab to the village. That is the grandest, because science exists to solve many problems in this world, but that science doesn't reach the villages where it is most needed. So we can sit here and talk about all the wonderful work that we do. But if there's no equity across the world, and the science hasn't reached there to solve those people's problems, then we are in trouble. So, the grandest challenge in global health. Their premise, these two guys, was that all lives are equal, are of equal value. What are the facts? If you are born in the UK, in the US, in Canada, in Germany, the chances of living to your 70s and 80s are very high. But if you are born in a country like mine, in a country like Rwanda, in a country like Kenya, that is not the picture. They say that people in these regions, their lives routinely and ruthlessly are cut short. They are cut short. Even today, hepatitis B vaccine was, discovered so long ago, but many of our countries do not give hepatitis B vaccine. Let's look at what happened with COVID. You all know the story. The Cambridge Africa collaboration should make sure, and if you wanted me to deliver one point today, that's the point. Cambridge Africa collaboration should make sure that science keeps the promise to all people, not just the rich. Life-saving science, not just the rich life science to remain with the high-income countries, but to go down to our people. And that is something that all of us as researchers should be committed to do. And lastly, to drive the point even further home, I went to Kenya because, again, through our Thrive work, to as we do, visit a student, PhD student, to see what he's doing. How is he doing the work? And the student was in Laisamis. That is a rural place. And honestly, while I've been to rural places in Uganda, which are very rural, I had not imagined that this is the kind of place I'm going to in Laisamis. And so these kids crowded around me. And those kids, they may be as bright as all of us who are sitting in this room, but there might be some who are even brighter than you and me. And therefore they are potential professors, they are potential presidents, they are potential great researchers. But the problem is they are born where they are born. They did not consent to their being born, let alone being born there, and yet the world treats them the way it does because science does not reach them there. It's like you being sent to prison for a murder you never committed, but simply because you are at the site of the murder, a crime you never committed. These kids have never committed any crime to humanity, but because they are where they are, they end up the way they are. That is why we should commit to the grandest challenge, which I said. And to me, that is the one message I wanted to deliver this afternoon. I thank you. Go and sit. Oh.
Thank you so much, Professor. That really, gives us a fantastic overview of how we got from where we are today. And thanks to the vision of Professor Sewankambo, Professor David Dunn, Kevin Marsh, many of the people in the room today. Thank you for giving that great overview, and thank you for being with us here today. We have a video on Cambridge, Africa that we're going to play now, but if the speakers for the next session could come and get themselves ready while the video was on, that would be great. Thank you so much. So thanks, Nelson.
Actually, from one of our PhD candidates, and it was then trying to go into the science to illustrate how our fellows work. And by the way, he hasn't completed his PhD, but he might complete early next year. He has already won a £500,000 from the Wellcome Trust for another, it is related research, but separate from his PhD work. So that's a flavor of what students are doing.
Participate in and lead clinical inquiry in critical care medicine.
I decided to go into acute respiratory failure because, as you know, a lot of emphasis is given to childhood pneumonias, but and very little is given to adults. And we know, other than if it's tuberculosis or HIV-related pneumonia, those people are left out. The care is not even planned for. If you look at clinical guidelines across the world, the care of a patient with respiratory failure just doesn't sit well. So I decided to study acute respiratory failure for my PhD to tell Africa's story.
When COVID-19 hit Uganda, it overwhelmed hospital emergency rooms and ICUs with patients. Uganda desperately sought the expertise of anesthesiology intensivists like Kwizera to secure the airways of critically ill patients and provide respiratory support with mechanical ventilation. Many patients were already suffering grave COVID-19 complications such as septic shock, acute kidney injury, and acute respiratory distress syndrome that required ICU admission for better management.
My PhD work was respiratory failure, and COVID causes respiratory failure, so I became a member of the Scientific Advisory Committee, Ministry of Health, and my focus was basically the research and clinical management. I also became a member of the Case Management Committee, coming up with adopting the guidelines that I had helped write in Geneva. It has been a humbling journey. We worked with the ministry to design specifications, equipment, as well as the building designs for the ICUs that would be set up at the regional referral hospitals. So when the COVID wave hit Uganda, we were fairly ready in some respects.
Although creative initiatives were undertaken by Uganda's government to convert operating rooms and sports stadium into ICUs, a major challenge of inadequate mechanical ventilators to provide respiratory support to patients with severe COVID-19 was rampant. To be able to match the high ICU demand and stave off ventilator shortage, Dr. Kwizera secured 25 cost-effective high-flow nasal cannulas and 250 CPAP masks from New Zealand-based manufacturer Fisher & Paykel.
When we were setting up these ICUs, we bought 200 ICU beds. Before that, we only had 30 functional government ICU beds. What we are now trying to do is say, okay, in the meantime, what can we do? We know the burden of respiratory failure. What else can we do? So this is where the other aspect of my work comes in. If you have respiratory failure, the go-to had been that you would need a mechanical ventilator. That costs about $50,000, and you need to be a specialist doctor and 2 years of added training to use it. On top of that, it has to be in a dedicated place, needs electricity, needs medical gases, and so on, maintenance. If I had 100 patients, all come with respiratory failure, can't I just maybe say, reduce the need for mechanical ventilation by 50%? So this is where this device comes in. This is just a high-flow oxygen machine. It's about maybe let's say 10, in terms of total cost, about 10% the price of the ventilator. This device can be used, does not need an extremely highly skilled person. This person just needs to know how to. The training they will take with just 1 week training to use it, and it can be applied outside the ICU environment.
With the curiosity of a child, Dr. Kwizera now seeks to compare the effectiveness of these two devices in reducing the need for mechanical ventilation. This year, he won a Wellcome Trust grant to conduct a clinical trial in 15 Ugandan hospitals to find answers to his research question.
Fisher & Paykel also donated 25 of these for the trial because they are also interested. This should have happened earlier, but because of the COVID pandemic, they didn't have any to spare. We also got a donation of about 250 CPAP devices. So at the end of the trial, we are donating all this to the sites that are participating in the study. So Mulago Hospital ICU, as you can see, we've given them 2, and if the recruitment rate is good, we can even give them more. So the 15 hospitals will share the 25 devices. And our hope is that becomes the new normal in caring for patients with acute respiratory failure as we figure out the longer-term issues.
Wholly, Dr. Kwizera's clinical and research career demonstrate that immense opportunities for innovation in critical care abound. What remains is to exploit available knowledge to promote innovation studies that enable faster application in clinical practice.
So I think that's a great video to demonstrate a fantastic Thrive project. So we'll give Arthur a round of applause.